Today's presentation, titled Pathogen Testing for Bloodstream Infections in At-Risk Patient Populations, is brought to you by the UC Davis Lawrence Livermore National Laboratory Point of Care Technology Center. We are an NIH-funded site. I am Nam Tran, postdoctoral fellow at this center. Our learning objectives are as follows. First, we will introduce sepsis, what sepsis is, including the systemic inflammatory response syndrome. We'll define sepsis, severe sepsis, and septic shock, the pathophysiology of sepsis, and examples of at-risk patient populations. Next, we will talk about different types of pathogen detection, such as polymerase chain reaction, and how this will then apply into patients who are at risk. And in this case, we use burn patients as the model to define and identify how nucleic acid recognition can accelerate treatment. We then look at an example of PCR-based pathogen detection in burn patients, specifically the Roche Diagnostics Septifast assay. And then we'll compare the value of qualitative versus quantitative pathogen detection in this model. And of course, we will then conclude with an overview of what we have discussed today. The learning objectives of this presentation will include providing examples of at-risk patient populations for septicemia, discern the difference between traditional sepsis definitions and burn sepsis, how key pathogens are associated with burn sepsis, and then understand the clinical value of the Septifast system in trauma, emergency surgery, and burn surgery patients. We will also learn and understand the clinical significance of discrete versus serial pathogen nucleic acid recognition, and as well as understand the value of qualitative versus quantitative pathogen nucleic acid recognition. This next slide is a picture of a traditional intensive care unit room. You see a bed, ventilator, monitors, as well as various containers for equipment and so forth. However, many of these surfaces are covered with a variety of contaminating organisms, such as Pseudomonas and all these other organisms that are the causative agents of ventilator-associated pneumonia, as shown here with the arrow pointing to the ventilator. The surface of carts, devices, and other equipment can contain pathogens, as well as other organic material. And other patient rooms can harbor organisms which can be transferred between patient rooms by healthcare personnel. Therefore, you can see that there are many possible ways which patients may become septic just by their stay in the hospital setting. Well, let's talk about sepsis. What is sepsis? Its significance is great. It affects 750,000 Americans each year. The mortality ranges between 28 to 50% in patients with severe sepsis and approaches 80% in cases of septic shock. It is the #1 cause of death in the non-coronary intensive care unit. It affects 1 in 4 globally. Numerous literature has been published over recent years on how to detect, treat, and monitor patients who have sepsis, as well as prevent sepsis in these high-risk patient populations. Some notable literature include a paper in 1999 by Dr. Marion Coloff out of Washington University. He found that inadequate treatment of infection among ICU patients appears to be an important determinant in hospital mortality. That is, if the patients were treated with the right antibiotic, an antibiotic that targets the organism or the organism is sensitive to the antibiotic. This would be termed as adequate. Inadequate treatment, on the other hand, is when you do not give the right antibiotic, or if the pathogen was resistant to the drug, then that would potentially cause an increase in poor outcomes in those patients. In 2000, from the same group, we find that administration of inadequate antimicrobial treatment to critically ill patients, specifically with bloodstream infection, is associated with greater hospital mortality. Essentially, Dr. Coloff and his group stated that if you do not treat the patients adequately within the first 24 to 48 hours, your patients will likely die. In 2001, Emmanuel Rivers et al. Did a study that showed early goal-directed therapy provides significant benefits, specifically in patients with severe sepsis and septic shock. They essentially developed an algorithm based on changes in the patient's physiology to implement life-saving countermeasures such as fluid resuscitation, antibiotic therapy, tight glycemic control, and so forth. This showed to improve outcomes significantly in this patient population. Of course, the take-home message is we need to know when to treat and what to treat as soon as possible. So here we have our sepsis definitions. Sepsis is defined as 2 or more SIRS criteria associated with a suspected or identified source of infection. SIRS is the Systemic Inflammatory Response Syndrome. It consists of 4 criteria, and as shown here: a temperature of greater than 38 degrees Celsius or less than 36 degrees Celsius, heart rate of greater than 90 beats per minute, respiratory rate of greater than 20 breaths per minute, or a PaCO2 of less than 32 millimeters of mercury. It also includes a white blood cell count of greater than 12,000 cells per microliter, or less than 4,000 cells per microliter, or greater than 10% band forms. If treated inadequately, sepsis may progress rapidly to severe sepsis, which includes organ dysfunction. Dysfunctional organs can be those lungs, liver, kidneys, as well as the heart, hypoperfusion, and hypotension as well. A subset of severe sepsis is septic shock, which is severe sepsis with hypotension despite adequate fluid resuscitation. As you can infer from this slide, the systemic inflammatory response syndrome criteria is extremely broad. Many of us out there, healthy or otherwise, can exhibit many of these criteria, can meet many of these criteria just by going out and exercising or being stressed and so forth. Therefore, this has been a challenge for clinicians out there in determining if these patients really do have sepsis, and this is further complicated in high-risk patient groups. This next slide shows the pathophysiology of sepsis. This is based on our general understanding of the mechanisms involved. It starts off at the top with the infectious insult, leading to an increase in pro-inflammatory mediators, leading to inflammation, leukocyte recruitment. These leukocytes not only destroy pathogens, but can also cause damage to the actual host. In this case, endothelial damage, leading to activation of the extrinsic coagulation pathway via tissue factor. This causes the formation of thrombin, and coupled to fibrin leads to coagulation, which hopes or tries to contain the infection. While in sepsis, many of these regulatory pathways, such as activated protein C, shown here in the middle, tissue factor pathway inhibitor, shown here in the pink above tissue factor, and the fibrinolysis pathway are compromised. Additionally, many of the pro-inflammatory mediators are highly upregulated, such as tumor necrosis factor alpha and so forth. With that in mind, these patients who are in sepsis have a massive systemic response to an infection. And it goes out of control, as you can see here with the broken lines, which are identifying compromised pathways. So the uncontrolled formation of thrombin, fibrin, and coagulation, for example, leads to thrombi, microthrombi, impacting organs with large capillary beds, such as the lungs, liver, and gut, hence leading to multi-organ dysfunction syndrome, one of the components of severe sepsis and septic shock. This is highly complicated in high-risk patient populations, as shown here. These are 3 examples of high-risk patient groups. Trauma, emergency surgery patients, for example, shows that in this population, the presence of trauma is a predictor with a p-value of less than 0.001, is a predictor of nosocomial infections, bloodstream infections. This is because trauma produces profound immunological dysfunction in these patients. There's also evidence that bacterial overgrowth and translocation from the GI tract combined with liver damage in trauma patients help facilitate these nosocomial bloodstream infections. Burn populations are also a very interesting high-risk patient group. These patients have lost their primary barrier to microorganism invasion, therefore are chronically exposed to the environment and their pathogens every day. Most of the time, these patients are in their ICU beds for a very large, lengthy length of stay, such as up to 60 days, for example. In the immunosuppressed, as one can can infer that due to their disease or the presence of chemotherapy agents that suppress their immune system, they are likely to have bloodstream infections or other types of infections by opportunistic organisms. We will now move on to a more detailed description of at-risk patient populations, specifically burn patients. This slide shows comparison of burn size and depth. On the left, we have the type of burn, and on the right, we have the actual burn size calculation based on the rule of nines. So let's start off on the left, burn depth. We have first degree burns, second degree burns, and third degree burns. This is based on a little bit more traditional nomenclature, where first degree burns are now considered superficial thickness burns, and second degree burns being considered as partial thickness burns, and third degree burns and fourth degree burns, which are not shown here, are considered full thickness burns. The first degree burns are, of course, the damage is focused on the epidermal layer of the skin. It's usually exhibited by a lot of erythema, and it includes types of burns such as sunburns, which we are all very familiar with. Second degree burns are obviously more deep. It includes partial damage to the dermal layer and exhibits blistering as well as additional erythema. There may be pain involved relative to the first degree burn, where first degree burns, as we all know from sunburns, are rather painful. Second degree burns, if involving nerve damage, may not exhibit pain. Third degree burns are essentially painless because the entire epidermis and dermis have been destroyed, possibly even as far as the hypodermis. Fourth degree burns, on the other hand, are as implied by the degree, are more severe and involve the underlying bone and or muscle. On the right, we have the rule of nines depicted over a diagram of a person in an anatomical position, with each area of the body based on about 9% of the total body surface area. So the entire arm circumferentially is considered 9%. The chest, the upper chest, plus the abdomen is considered 18% for the front, and the entire back is also another 18%. The head circumferentially is 9% and so forth, and this all adds up to, of course, 100%. Many of these components decide if a patient will go to the operating room and how much fluid resuscitation they would need. And fluid resuscitation is a major component of burn treatment, especially in the first 24 hours, where it is based off of a mathematical formula called the Parkland's formula, and it uses 4 mLs of fluid for resuscitation per kilogram per total body surface area burn, with the first half of that value that you calculate given over the first 8 hours, and the remaining half given over the next 16 hours. So this massive fluid resuscitation to prevent burn shock can contribute to the underlying factors that increase mortality and morbidity in this patient group. We will now go to one of the biggest players of mortality in this patient population, and that's burn-related sepsis. Here, our systemic inflammatory response syndrome criteria that we defined earlier no longer necessarily applies. This is because the pathogenesis of sepsis, although being the same in this patient population, we now need to define burn systemic inflammatory response syndrome. This is because of the altered metabolic profile in burn patients. The traditional sepsis definitions do not apply here. In actuality, the actual American Burn Association sepsis guidelines stated that the traditional SIRS criteria become so inclusive as to be meaningless. And here are some examples. The higher metabolic rate of these burn patients lead to a higher body temperature. So their basal temperature is now reset at 38 degrees Celsius or a little bit higher. Since their entire body, or whichever percent total body surface area that's burned, is considered a wound and it's there for prolonged periods of time and exposed to the environment as well as pathogens, these patients exhibit a chronically elevated white blood cell count, rendering white blood cell counts as unreliable markers in SIRS and sepsis. We also have to think about the counter anti-inflammatory response syndrome, which occurs relatively frequently in these patients. It is essentially the opposite of SIRS, where the patient's immune system is depressed due to an upregulation of anti-inflammatory cytokines and chemokines. Additionally, as I implied earlier, many of these interventions, such as the use of the Parkland's form, which saves the patients from burn shock, may contribute to future comorbidities. Additionally, these patients who have infections have interventions during sepsis that lead to future complications, including loss of skin grafts, increased episodes of infections, and sometimes amputation of the limbs. We now redefine the sepsis criteria for burn patients as the following. The burn SIRS criteria includes temperature greater than 39 degrees Celsius or less than 36.5 degrees Celsius, a heart rate of greater than 110 beats per minute, respiratory rate of greater than 25 breaths per minute when not ventilated, or greater than 121 breaths per minute while being ventilated, a platelet count of less than 100,000 cells per microliter, but this is only valid after 3 or more days after resuscitation, hyperglycemia in presence of pre-existing diabetes, nutrition, that is, an inability to continue enteral feedings for greater than 24 hours. Now, for burn patients to have sepsis, they must have 3 or more of these criteria rather than 2 in the previous traditional criteria, along with a suspected or identified source of infection. The severe sepsis category is dropped in burn patients, and the septic shock criteria or definition remains the same. Burn-related sepsis, the pathogens involved are actually relatively common in the ICU population, but organisms that are usually fewer in numbers occur more frequently, such as gram-negative, resistant gram-negative organisms and fungal pathogens. These may be more analogous to the immune-compromised group, and many of these patients, burn patients, are essentially immune-compromised to an extent since they have lost their primary barrier to infection, that is, their skin. 97% of patients with greater than 20% total body surface area burns develop septicemia. Most burn-related deaths, 54%, are due to septic shock. Gram-positive infections are the types of infections that occur in burn patients early on. This includes Staph aureus, methicillin-resistant Staph aureus or sensitive Staph aureus, as well as coagulative staph, with the latter being potentially a contaminant, as in other patient populations. Gram-negative infections occur later in their hospital stay. This include endogenous gram-negative pathogens that live in the patient's GI tract or elsewhere on the skin. This includes Klebsiella species, Pseudomonas aeruginosa, E. coli, and Enterobacter species, with Pseudomonas being the number one cause of death in burn patients, followed by Klebsiella. Fungal infections are more complicated. They include the usual issues, which usual organisms such as Candida albicans and Candida parasilosis. However, in these cases, mortality approaches 100% in this patient population when there is an invasive fungal infection. We now move on to pathogen nucleic acid recognition. As shown previously, these pathogens that infect burn patients are attributed with extremely high mortality. Of course, like other patient groups, burn surgeons rely on the age-old method of culture to detect these pathogens. Here, the slide shows a sheep blood agar plate. Culture is dependent on the growth characteristics of the organisms. Therefore, if you have the wrong media or the organism is fastidious, has a slow growing time, you have to wait until it achieves the appropriate amount of pathogens to show up on the culture to allow for speciation. In this case, on average, speciation can occur 24 hours after sample collection. This led to the development of new detection modalities such as nucleic acid tests, or NAT. Nucleic acid tests, such as those dependent on amplification methods, in this case polymerase chain reaction. Polymerase chain reaction, or PCR, was developed by Dr. Kerry Mullis out in California, and essentially it relies on the standard concepts encompassing DNA replication, where first you must denature the DNA. In this case, we heat it up. This provides single-stranded DNA to allow binding of primers, and then followed by cooling to allow DNA polymerase to elongate these strands. Then the heating cycle is started again to denature the DNA to start the whole cycle all over again. And then you'll, of course, have an exponential increase in the number of DNA copies over time. This, in short, increases the amount of DNA that you started off with to allow for a strong enough signal so that you can detect small amounts of pathogen DNA from a sample. These pieces of DNA, as shown here in this slide, may be detected through a variety of mechanisms, such as fluorescent detection. This fluorescence-based detection method is highly specific, since in the next slide you see a method called fluorescent resonance energy transfer, or FRET. FRET relies on engineered hybridization probes. These pairs, shown here in the upper left, the anchor probe, and on the upper right, the sensor probe, bind to a specific area of a target piece of DNA. The anchor probe has a fluorophore which is excited by one specific wavelength. In this case, it is the blue wavelength. The sensor probe is not excitable by the blue light. However, when brought into close proximity with the anchor probe through the intended binding target of DNA, we have the sensor probe's fluorophore becoming excited and emitting a red light. And this is detected by your pathogen detection method and tells you that you have the correct sequence of DNA being detected by the device, and thus being positive for the organism of interest. You can further differentiate between subspecies of pathogens by conducting melting point analysis, as shown at the bottom of this slide with the symbol TM, which is the DNA melting point. Due to sequence polymorphisms among subspecies of bacteria, you'll have different melting points for the sensor probe. So as the sensor probe melts away, you lose the FRET signal, which then allows you to determine if it's organism A versus organism A prime. For example, Streptococcus agalactiae versus Streptococcus pyogenes. This next slide shows microbiological device such as blood culture compared to molecular diagnostics. In this case, a molecular diagnostic device is Septifast from Roche Diagnostics, and it utilizes the FRET mechanism to determine what kind of organisms are present following a PCR reaction. It actually targets 25 different organisms as shown on the list previously, while blood culture, shown on the left, requires time to growth, incubation, as well as detection via gram staining and other biochemical tests. And of course, you are completely dependent on the growth characteristics of the organisms to get to a result. We will now apply these concepts in the next segment of this slideshow, where we use Septifast in the burn patient population. This first slide here shows the Septifast detection panel, which includes 25 different organisms, inclusive of gram-positive, gram-negative bacteria, as well as fungi. Of note, MRSA detection here, shown on the left, is actually a separate test kit which adds an additional hour to the 5-hour Septifast assay turnaround time. This is quite useful, as you can see here, where the PCR component of Septifast allows for same-day testing in this colored region. In contrast, these curves, the blue, red, and green curves, are the actual temporal distribution of 3 different blood culture timing events. The blue shows the time from blood draw to speciation results. The red zone shows the time from speciation results to qualitative differentiation of the actual organisms, and the green curve shows the time of speciation to the minimum inhibitory concentration, that is, the drug sensitivity results. In our study here at UC Davis Medical Center, we looked at 50 different patients, 30 of which were from trauma, emergency surgery services, and 20 from the burn surgery service. Of course, the organism that was most prevalent in both patient population was Staph aureus, subdivided here in these pie charts to methicillin sensitive and methicillin resistant Staph aureus. Other organisms of note, we have a great deal of other gram-negative organisms such as Enterobacter species, as well as Pseudomonas aeruginosa and Acinetobacter baumannii, which were actually found by the blood culture methods. In non-blood culture type tests, this includes wound cultures and sputum cultures, we have similar distribution of organisms, but we also have here included on these pie charts Haemophilus influenzae, which is a sputum, a respiratory tract infection organism. Moving on to this next slide, we now show the utility of PCR-based tests in the patient population. Here we have a trauma/emergency surgery patient. This patient is a 42-year-old woman with a perforated jejunum, status post-exploratory laparotomy, and a small bowel resection who developed septic shock 24 hours later following surgery. So here we have a timeline showing day 1 where she had her XLAP bowel resection and was returned back to the intensive care unit with an open abdomen and was started empirically on ceftriaxone and Flagyl. 24 hours later, she exhibited signs of septic shock over the course of 3 hours, where the nursing staff tried to maintain her mean arterial pressure above 65 millimeters mercury. Her temperature was 38.6 degrees Celsius. White blood cell count was 3.1. Blood pressure 81/61 with tachycardia of 129 beats per minute. No blood cultures were taken until day 4, where PCR samples were drawn and identified Klebsiella pneumoniae and Oxytoca, as well as Enterobacter species. Blood culture was negative, likely inhibited by the antibiotics that are currently on board. The patient remained febrile at temperature 38.6 with leukocytosis at 18.2. Urine cultures were also negative. Antibiotic dose was increased in view of the patient exhibiting edema, which increased the volume and distribution of the antibiotics. By day 6, another set of blood culture and PCR samples were collected. Blood culture remained negative. PCR detected Klebsiella species from the catheter line, and both Klebsiella and Enterobacter species were detected by PCR from the peripheral sample. The antibiotics that were used on the first day were discontinued and replaced with piperacillin tazobactam. The patient continued to be febrile at temperature of 39 degrees Celsius, white blood cell count of 20.4. She began to improve over the next few days after being started on piperacillin tazobactam. Her temperature was reduced. She was started on ciprofloxacin and vancomycin for empiric treatment for Pseudomonas aeruginosa and MRSA respectively. Her white cell count began to go back down to 16.2 on day 9. By day 10, her temperature normalized. White cell count was continued to drop down towards normal levels. She went to the OR for abdominal closure, and her temperature by day 11 was normalized, and her white blood cell count was relatively unremarkable. She was transferred to the floor by day 17. Here we can hypothesize that serial PCR testing can detect pathogens which blood culture missed, potentially due to 1, altered pathogen distributions during septic shock, 2, antimicrobial therapy inhibiting blood culture results. So, thus, PCR may serve as an adjunct to blood culture methods while patients are on antibiotic therapy. This next slide shows a patient who is an 87-year-old woman presenting to the medical service with recent onset of food regurgitation. At time of consent, she was diagnosed with duodenal obstruction and was status post gastrojejunostomy and bilateral oophorectomy. At the time of consent, which was on day 25 of her hospital stay, she was febrile with a white cell count of 18.2. She was pan-cultured with urine, respiratory, and blood culture samples drawn. PCR samples were also drawn at this time. Urine culture showed up the next day as positive for Pseudomonas aeruginosa, and she was started empirically or immediately on cefepime and ciprofloxacin. By day 28, she continued to spike a fever at 38.9, white cell count 5.2. Respiratory cultures from the previous set showed up as MRSA. Blood cultures reported Enterococcus faecalis and Candida albicans. She was started on vancomycin and fluconazole, with fluconazole being an antifungal drug to treat the yeast Candida albicans. PCR results taken roughly at the same time reported Candida albicans as well as Candida tropicalis. Candida tropicalis may be potentially a resistant fungus. Her temperature continued to increase to 39.3 degrees Celsius. White blood cell count remained unremarkable at 6.5. Additional cultures were collected, including blood cultures and urine cultures. 2 days later, urine cultures reported back with Candida albicans. Blood cultures reported back as well with the same organism. She remained relatively febrile. White cell count continued now increasing at 17. Over the course of her stay, there were reports of adenocarcinoma. Due to her deteriorating state, she was placed on comfort care on day 32 and the patient expired on day 33. The value of PCR in this patient case was early detection of high-risk organisms such as Candida albicans and other species of fungi. In this case, we found that our method, PCR, detected the organism at least 24 hours earlier. However, due to the patient's age and other comorbidities, it is likely that PCR may not have helped this patient in the end. Regardless, based on these two patients, we can potentially hypothesize the potential benefits of qualitative versus quantitative results. Here we have a slide showing a curve with the y-axis of colony forming units per ml, that is the pathogen concentration, and the x-axis as time, could be on the order of minutes, hours, or days. Over the course of time, you can see that the pathogen early on will have an exponential growth period when they are uninhibited by antimicrobial therapy. Antibiotics have not been given yet, and the immune system has not had time to mount a response yet. Well, at the arrow showing the initiation of antimicrobial therapy, you can see attenuation or slowing down of the growth of the pathogens. Following revision of antimicrobial therapy to a more targeted treatment regimen, you can see a microbial static effect where the organisms do not grow, and towards the end of this curve we have a decrease in pathogen concentration, which is based on clearance by antibiotics as well as the host immune system. So thus, in summary, this graph here shows the in vivo pathogen concentration. Well, now building upon this with the detection method that is generally accepted as the only method for determining if a patient has bacteremia. This is culture. Culture methods are generally qualitative in nature. In some cases, they may be semi-quantitative, where they report back 1+, 2+, 3+, or 4+ organisms, as shown here. So essentially a yes or no response if the organisms are there or not. Well, this graph above on its y-axis shows the number of colonies that are grown out of the culture taken at different discrete time points throughout this patient's hospital stay. You can see that the organism initially before antibiotic therapy showed as 4+ on the culture result. As antibiotics were started, this amount decreased to 2+, and when antibiotics were in full effect, there is what we call clinical blackout, where the clinician doesn't really know what's going on in there, even though pathogens are still inside the patient, perpetuating a septic response. But since antibiotics are attenuating growth of the blood culture media and the organisms, we do not know what is going on with this patient. To answer these questions on how do we determine if there are organisms still growing during antibiotic therapy, we now move on to the concept of quantitative pathogen detection. So we now have a third component to our figure here. At the very top, we have a new curve shown in green. The x-axis here is, of course, still time relative to the two previous graphs. The y-axis shows DNA per milliliter, so analogous to colony-forming units per milliliter. However, it might not be the exact amount. This is based on nucleic acid recognition, such as PCR. We can now determine how many pathogens are there over time, even when antibiotics are present. The clinician can now, during treatment of antibiotics, can monitor if pathogen loads decrease or increase or stay the same during treatment. Gives the clinician data during the clinical blackout component found in culture methods, while monitoring as closely as possible or estimating the amount of pathogens in vivo. The evidence for quantitative pathogen recognition are as follows. It can, for antimicrobial efficacy, pathogen DNA concentrations found to decrease adequate antimicrobial therapy, and it also corresponds with normalization of body temperature in a recent paper by Peters et al. Quantitative pathogen nucleic acid recognition can also determine disease severity. It is found that high pathogen DNA concentrations correlate with disease severity in patients with meningococcal infections. All these concepts are very analogous to viral load testing. It's been used a great deal for human immunodeficiency virus testing and treatment. Ultimately, this can serve as an alternative to quantitative culture. Quantitative cultures have been around for a while, however, they have not been adopted because of their lack of cost effectiveness and lack of accuracy. So therefore, nucleic acid recognition, specifically quantitative nucleic acid recognition, can help in this area. However, there are drawbacks with nucleic acid recognition. There has yet to be a fully definitive explanation of DNA-emia, that is DNA in the blood. Nucleic acid recognition is unable to discern between killed versus viable pathogens. Therefore, when you're treating a patient based on PCR results, for example, are you treating organisms that have been destroyed by your treatment? Is the DNA actually clinically significant, or is the signal that you're detecting actually a real organism perpetuating the sepsis response? DNA fragments are another concern. Their fragments of DNA containing multiple target sequences may falsely elevate the quantitative results. Antimicrobial therapy can also have confounding factors because microbicidal antimicrobial drugs may falsely elevate the DNA because you're lysing the organisms and allowing the DNA to leak out. Lastly, and potentially the most confounding, is where do we treat? We have no idea. There are no standards to interpret bacterial and fungal DNA loads. Is a certain amount of DNA per mil more important than the others, and so forth. There has been some work, of course, in trying to answer these questions, and this is based on what we call pathogenekinetics. In this case, pathogen kinetic modeling, as shown here in the 4-compartment model, analogous to pharmacokinetic modeling, where absorption, distribution, metabolism, and elimination still plays a role. This study by Chung et al. Tried to determine the pathogen concentrations in a dynamic state during sepsis. So do pathogens third space into other compartments due to the altered hemodynamics manifested in septic shock. Fluid resuscitation may also affect pathogen loads, where you're bolusing patients, as discussed previously regarding the Parkland's formula. You may be diluting the pathogens or pushing them into other compartments in the body. In the end, despite all these differential equations and multi-compartmental modeling, pathogen kinetics during sepsis is still largely unknown. Therefore, future studies are needed to answer these questions. Therefore, we can now conclude that pathogen nucleic acid recognition may be a valuable adjunct to culture-based technology, especially in burn patients where it may be unfeasible to start antimicrobials after blood culture. The synergy of microbiological data, such as blood cultures and non-blood cultures, coupled to nucleic acid recognition, improves clinical decision-making by the critical care team. Serial nucleic acid recognition testing, however, could also prove useful in monitoring the efficacy of antimicrobial therapy, as shown in those 2 patient cases. Analogous to viral load testing for HIV, application of quantitative serial bacterial or fungal testing may immensely impact high-risk patient groups such as burns. But of course, as I stated just not too long ago, there's still a lot of work to do. We need to know when to treat based on DNA results, how much is clinically significant, and what happens to pathogens as well as their DNA during the sepsis cascade and septic shock.